So what we're going to do today is we're going to review pediatric seizures, different seizure types, and the surgical options that are available when seizures are hard to control with medication. So in general, if we look at the numbers for pediatric seizures, about 1% of all emergency department visits for children less than 18 years of age have to do with seizures. So that's a fairly large number of patients coming to the ED. 5% of pediatric patients will experience a seizure by the time they are 16 years of age, but having one seizure does not diagnose epilepsy. Epilepsy is diagnosed when seizures are unprovoked and recurrent. But in general, the number here says 42% of patients will have a 5-year recurrence. Basically, what we quote to families is about 40 to 50% chance of having a recurrence. If you have a second seizure after that, the incidence increases. So the more seizures you have, the more you're likely to have the next seizure. So we're going to look at these videos and then ask people what the seizures are like. So if we take a look here at this child. All right. When we're evaluating seizures, one of the things that's important is the description of the event, which we just saw. And this is usually obtained from the history, the families coming in and telling us what they see. But however, now everybody is carrying around a camera in their pocket. So we now are able to use a lot of the home videos as well to help us classify the seizures. In the past, the videos were usually limited to the epilepsy monitoring unit where we would admit people for inpatients. The thing about a febrile seizure is you really can't say from looking at a seizure, is it a febrile seizure, because they can have all different kind of manifestations. What makes it a febrile seizure would be the fact that the patient also has a temperature elevation at the time of the seizure. But most of the febrile seizures that children have will be the tonic-clonic seizures. So they're typically defined as having a temperature elevation greater than 38 degrees centigrade. There's typically a loss of consciousness with a seizure, and they are typically shaking of the arms and legs, what we would call a generalized tonic-clonic seizure. Tonic meaning a stiffening part of the seizure, and the clonic meaning sort of what we would call the jerking. And while these, of course, are frightening for parents, they're usually harmless and typically don't indicate a serious health problem. But I have to add and say that for every time you see any patient with a seizure and a fever, in your mind you have to ask, could they have a central nervous system infection? And so that is part of what we always do for a febrile seizure. We may answer that question by observation. If the child is up and running around and looking well, we may not do any further studies. But if they're not looking well, we might then do a lumbar puncture. So let's look at the next one.
He went online, he done all the booking.com, and went on booking.com.
This is what's called an absent seizure, or what we also call a pediatric seizure. We don't use so much in our medical lingo the term pediatric seizure. That actually comes from the French meaning, I think, minor illness, as opposed to the grand mal term, which means a big illness. We typically say generalized tonic-clonic for the grand mal, but the absence is, yes, a type of seizure in which there's a change of consciousness, particularly with staring. It's a staring spell, but also sort of an absence of function. So a lot of times you'll see, like in that girl's face, that she was talking, she stopped moving, her face became not frozen, but not moving. But she also had some automatisms. We saw her swiping her nose, and then she picked up and started talking at the end of it. So patients may maintain their posture during this type of seizure. Typically, they will have eye blinking. So if there's any outward motor movement, eye blinking would be the most common thing that they do. These typically last no longer than 30 seconds. We have a particular pattern on the EEG, what we call the 3 Hertz spike and wave discharge. And actually, we can bring these out during the EEG with hyperventilation. So the patient breathes in and out quickly, and they'll develop the episode. And there have been several patients that I've had over the course of my career where even before the EEG, I've hyperventilated them in the office, I see the typical absence seizure, and then I may start treating them even before I get the EEG. But we also have to say that other seizure types can be activated with hyperventilation, so we do have to be careful about that. But the child may not recall what just happened and may go through their activities as though nothing happened. I have seen some children that at the end of this seizure, they do recognize that some time has gone by and they have missed something. These typically occur several times a day. And in fact, if someone comes in and tells you they're only having a couple here and there, then we have to be suspicious of that diagnosis. They typically start off in younger children, 3, 4, 5 years of age, in sort of like a crescendo pattern where you might see a stair and then they increase, increase, increase. So not uncommon for the parents that when they finally come in to say, well, we may have started seeing these things months ago, but they're hard to define clinically. So let's look at the next one. So yes, we can say, what kind of seizure is this? And Gelastic is the correct answer. And if we move on to say Gelastic seizures are seizures in which there's the predominant seizure type of where they have laughing. And this can be kind of not like a mirthful laugh. Sometimes people will say it's laughing without mirth. Sometimes patients can cry during these. But they may not have any other seizure type. So it can be very difficult for people to really recognize early unless you're aware that this can happen. It's slightly more common in boys. It's rare, and probably out of 1,000 children with epilepsy, there's probably only 1 or 2 who will have gelastic epilepsy. We happen to see a lot of this at TCH. Dr. Curry will explain to you why. The most common areas of the brain which give rise to gelastic seizures are the hypothalamus and the temporal lobes around it and the frontal lobes. And there is a tumor in the hypothalamus called a hypothalamic hamartoma, which would be the most typical abnormality that you would see with this. And the majority of these tumors are benign. And as the bottom of the slide says, gelastikos is the Greek word for laughter. So that's the etiology of calling these gelastic seizures. So again, very important to recognize. I did see a patient once who had won a happy baby contest at 4 months of age because the baby was laughing all the time, and it turned out that the baby had a hypothalamic hamartoma with gelastic seizures. So if we say when to worry, because sometimes it can be very hard if people are laughing to say, does this require referral? The presence or the association of precocious puberty with it would make this a lot more likely. So, and the reason for that, of course, is because of the hypothalamus and the hypothalamic pituitary axis would make us very concerned about that semiology. Semiology is the word we use, meaning the description of the seizure. They also can have learning problems, behavioral problems, and the reason we think that is even without seizures, there's a term called epileptic encephalopathy in which the brain gets bombarded by spikes. And we think that this is a very epileptogenic lesion sort of sitting in the deep part of the brain, firing off a lot, and therefore leading to the cognitive and the behavioral problems. Now let's look at this one. And so what do we think of this seizure type? And that is right. That's a tonic-clonic seizure. The seizure there, the tonic refers to a phase of muscle contraction in which it's sustained, a sustained contraction, and the clonic refers to sort of the breaking up of it or the muscle jerking. So we think that what's going on is that there's excitation giving us the tonic phase with multiple spikes happening, and then it's the brain inhibitory activity coming in and causing the clonic phase by breaking that up. So when we think about epileptic seizure types, we talk about the seizure type. So we've seen the absence. Myoclonic is the same as clonic. It's just a very rapid muscle movement. Epileptic spasms or infantile spasms, West syndrome, another important seizure type for people to know about, because these babies typically present between 4 to 6 to 7 months of age with a very sudden kind of muscle jerking myoclonic or tonic seizure. And important to know about and refer because there's a typical EEG pattern associated with that called hypsarrhythmia, and we think that getting these seizures under control as soon as possible helps with the brain development. And the atonic-tonic seizure is really a more prolonged tonic seizure as opposed to the tonic-clonic. But one of the concepts that we have in epilepsy is whether a seizure is generalized, which means where the seizures start in the brain at the onset. So generalized, of course, would be both hemispheres, versus a focal seizure, meaning that the seizure is starting in one particular area. And this is very important for, number one, us choosing the proper medication for people to be on, because the seizure meds typically work against a generalized or against focal seizures, and then becomes important if we're evaluating the patient that's hard to control for epilepsy surgery. So there are other events that can happen that mimic seizures, and what can be important for this is the history, how the activities start or their onset, how long they last, what the movements look like, whether there's a recovery or a post-ictal phase, and very important is there a precipitant? If there's a specific precipitant that brings on some kind of event, then that may make us think more of a vagal response or some other kind of event that could also cause syncope. Other helpful specifics would be whether there's associated eye movements, tongue biting. However, tongue biting, just as an aside, if you have a syncopal episode, you could bite your tongue, and you could bite your tongue with an epileptic seizure. But for a syncopal episode, the patient may bite the tip of their tongue, whereas for a seizure, they may bite the lateral part of their tongue. Whether or not there's urinary incontinence, although that can also happen with a syncopal episode, and whether there's an aura, meaning some type of an event that happens before the seizure. Pediatricians can encourage their parents to gather information. I'm not going to go over this form, but this is something that you can get from epilepsy.com. And then what happens after the referral. And what we're showing here is our epilepsy monitoring unit. So for the epilepsy monitoring unit, this would be the part of the hospital, of the neurology floor, where we bring the patients into the hospital, we record their seizures, and that helps us, number one, say, is the seizure an epileptic event? Or then to work the patient up for epilepsy surgery, because if we can find a seizure coming from one spot, then we may refer them to Dr. Curry for consideration of surgery.
I'm glad that we put this together with Jim, because it hammered home the point that a lot of epilepsy management is medical first. It's mostly a medical scenario in which we are encountering a continued number of seizures, and 70% of the seizures that are out there in children are going to be able to be controlled with a proper medicational or a proper medicine design. But primarily we're looking at the kids that don't respond to that, and they're defined as having 2 properly dosed and properly timed anti-epileptics over a certain amount of time. That amount of time is somewhat of a debatable scenario. But if that is the child that we're looking at, we know that the probability of them being cured on the 3rd medicine is 4% or less. So then they become a surgical candidate. And I'm going to go over some of those strategies here. So in epilepsy surgery, we think in terms of 2 major groups of surgeries that we do. We first think about the therapeutic surgeries, which are going to be at the end of our workup. Generally, those are broken down to me in 4 big categories. The one that is most commonly understood and one most commonly offered in most epilepsy or most major medical centers in the United States is the standard resective epilepsy surgery. In other words, we have to do an operation on the child's brain in which we make an incision in the scalp, you open the bone window, you open the dura, and you take out the portion of the brain, whether it's the lesion or whether it's the whole lobe, that is causing the seizures. And we've been doing that for 100 years now. We're pretty good at it, but clearly that's a big operation. The next big category is something we're very fond of here at Texas Children's Hospital as part of a minimally invasive effort, and that is ablative neurosurgery. Basically what this term means is you are able to destroy the source of the seizures within the brain without having to do a large opening, without having to do that open craniotomy and put your hands on the lesion. We do this in a number of ways. The most common way that we do this now is MR-guided laser ablation. In other words, we are putting a laser within the lesion and having that laser turn on and heat up that target. And we can destroy that target with just a little incision, maybe 4 millimeters or so. Other ways of doing that, we've been thermally ablating things in the brain for 50 years or so. There's other ways, but that is the best way of doing it these days because we can see it, and I will show you why. The next big category is something called disconnective surgery. Sometimes the area of the brain in the child is so large that you can't really, or you can take it out, but it's going to have complications in taking it out. The skull does not like a vacuum. So, and you may have heard of these hemispherectomies where we take out the whole hemisphere. We still do that when we absolutely have to, but when we have an opportunity, we'd rather just disconnect that part of the brain, the bad part of the brain, from the good part. And usually this is in something called a hemispherectomy where we get inside the brain in an open operation and disconnect the connections between the bad and the good, or sometimes we can just take out the posterior aspect of it. Generally, though, the principle is to leave that area of the brain there, but as long as it's been disconnected from the rest of the brain, it's not going to impart the seizures into the whole brain. And the last category is something we're getting more and more referrals about is the stimulation world. In the grand scheme of things, we call it neuroaugmentation. That's just trying to include a bunch of other therapies. But in stimulation in epilepsy, the concept is if there is a part of your brain that's abnormally firing off, as it is an electrical signal at the cells, maybe we can apply an electrical field in some area and stop it. Most common way that we do this these days is something called vagus nerve stim, which is something was discovered maybe about 80 years ago, that if you find the vagus nerve in the neck and you stimulate that, it can actually increase the brain's threshold to have a seizure. It actually engages the brain's own ability to stop these seizures. But it is what we call a palliative operation. In other words, we're not out to cure anybody with a vagus nerve stimulator. We're out to lower that seizure burden so maybe they can have a little bit more clarity in their thought. Maybe they can have a little lowering of the side effects of the meds that they are on. Lately, however, we have had a different sort of neurostimulation system that may actually have the ability to cure a few people, and that is called the responsive neurostimulation system, called the RNS. And this is a very exciting new technology and new development, concept being it's like a pacemaker for your brain. If you think about abnormal heart rhythms, that's an electrical phenomenon. We can cure it by putting a wire, detecting that abnormal phenomenon, and simply zapping it back into its normal rhythm. This is what we're doing in the brain now. It's a little bit more complicated because there are larger areas and some of the targets can be deep. But this notion that we can put now wires and electrodes inside the brain, measure the seizure as it comes up with a little computer that I install inside the skull. And then when it knows it's having a seizure, it turns around automatically, fires off a small signal that they don't feel, and stops the seizure. That has about a 50% cure rate in some categories. So we are doing this in children pretty commonly now. It's a good alternative for the scenarios in which we can't take out the source of the seizure because it may harm the child. The other big category that you may hear about in epilepsy surgery is the diagnostic procedures. Basically, we boiled down epilepsy surgery into 4 phases. In phase 1, we try to do all this non-invasive testing, the MRI, the EEG, the PET scanning, all those things, and we accumulate all that data into one understanding and one hypothesis of where we think within the brain the seizures are coming from. That's all phase 1. Everything else is going to be invasive in some way. Phase 2 is when I have to put electrodes in or on the brain to confirm the hypothesis that we came up with on the non-invasive, the workup. Basically because all that non-invasive data has caveats. It can be inaccurate in many, many ways. So we have to confirm it by putting electrodes where we think they're coming from, put the patient in that epilepsy monitoring unit that was just shown, let them have some seizures on video so we can confirm it, but most importantly, look at the electrodes in the brain as the seizure is occurring and know which of these electrodes in context they're coming from. That confirms the target of what we call the seizure onset zone. We also sometimes have to do this in 2 ways. We can either do an open craniotomy and put the electrodes on top of the brain, but more preferably what we've done lately, really for the last 5 years, is put multiple depth electrodes inside the brain. And this may sound pretty invasive to this audience that you're poking 28 wires inside the child's brain. Is this not going to injure them? Well, it turns out it's pretty non-injurious when you look at it from the grand scheme of things. Any child's brain or any adult brain, but scale it down slightly to a child, if you unfold all those gyri of the brain, you have a 2 square meter surface of brain, and each of these electrodes is 1 millimeter. So in that context, we're injuring very little brain. And as far as the skull goes, in the surgery, we're doing a 4 millimeter incision in a 3 millimeter hole. So children tolerate the stereo EEG far better than they tolerate the open craniotomy and grids on, and that's what we have preferred over the years. The next big phase is once we have figured out where the seizures are coming from, now we got to figure out where we can't operate, where we can't go without harming that child. And that's called phase 3, and sometimes that also needs an open craniotomy or these depth electrodes to confirm that one area of the brain is the area of the brain that child uses for speech, or the other area of the brain is the area of the brain that child uses to move. Those are areas that we can't go without harming the child. That's phase 3. And phase 4 was the therapeutic options that I referred to in the first slide. So here's some examples of what we can do these days. So we're always, at Texas Children's, we try to be as minimally invasive in epilepsy surgery as we can. And I'd say 85% of our procedures, maybe even higher now, are minimally invasive operations. One way you can do some of these disconnection things that I mentioned before, we have to get inside the brain and cut the fibers going from the epileptic part of the brain to the non-epileptic part of the brain, is you can do an endoscope. You can do a small camera that's put inside the fluid-filled part of the brain and work inside that. And if you have an assistance with a robot, you know exactly where you are at each time. And this is an example of an endoscopic corpus callosotomy. That just means I'm trying to sever the connections at the top of the brain from one side to the other. Here's an example of that stereo EEG. To the left is the robot that we are using to guide us. Robotic pediatric epilepsy surgery is a brand new world. We've been doing it for about 5 years or so, and has really revolutionized the way we do surgery, because in a lot of these electrodes, a lot of it is redundant, but it has to be a precise placement down to the millimeter, actually down to the half. So basically, it's a lot of calculating that is prone to human error. In the robotic world, we can put these plans into a computer, and I can have this robotic arm, as you see on the left, guide me to exactly where I designed to put that electrode on that child's MRI, but I can do it in the real world. And that has really allowed us to facilitate large numbers of electrodes inside the child's brain so that we can get a very good view of the three-dimensional network of the seizures. And this is what the child looks like when we're done. There's these bone anchors that are holding on to the wires, and the wires are sewn to the skin. Laser ablation surgery is something we pioneered at Texas Children's, and basically what it boils down to is it's an attempt to minimally invasive destroy the source of the seizure without resorting to the open craniotomy that most people do. Here's an example of the small area that I'm using, the small incision that I'm making to put the probe inside. To the left, I'm using a frame to guide me. To the right, you can see the size of these things. It's a 4 millimeter hole, or 4 millimeter incision, 3 millimeter hole, and it's held in place by this tiny plastic a screw. And basically what it's going to hold on to is a cannula that lets a laser fiber go to the target. That surgery is a good advance all by itself, but really what allowed us to have it happen was MR guidance and the fact that we can see it in real time on the MRI scanner. Basically, when you're doing epilepsy surgery, you really need to see what you're doing, right? It makes perfect sense. And the way you do that is you do these big open operations and you put an operating microscope down into the ventricle and you're seeing every little move. And that's why we didn't want to do these minimally invasive operations, because we really couldn't see what we're doing. Back in the old days, we would put little probes in the brain for movement disorder and just have to rely on our calculations to know that we were in the right place. Why? Because it was metal and we couldn't image everything. Now we have the ability to put these probes in, they're MR compatible, and this laser I can see happen. But most importantly, when I turn on the laser, I can actually use the MRI to see the heat. And that's what this slide is going to show you. It's a bit of a long video, but the notion here, let me back it up and tell you about this particular kid. This is a kid that had the Gelastic seizure that you saw in the video. It's a very characteristic lesion in the bottom of the skin. I got my cursor over it here. It hangs down to the very deep part of the brain, so you can see the EEG in the top is never going to reflect what's going on down here. Here is a cannula that we have put through a tiny hole down to the target. And what you're seeing here is the heat increase on this lesion. And here is a computer evaluation of damage that heat is doing, changing each pixel to the color of a lesion. And as that, what is called an irreversible damage map, covers my target, I know I'm done with my operation. And this is zoomed up a little bit, but this is in real time. You can see the laser powers going on and off below the line there. So this is the revolution that we've had in epilepsy surgery, is we can see the heat do the job, whereas in stereotactic or other minimally invasive operations in the past, we just had to rely on our numbers, and that is a very unsettling way of doing this work. Now we can see it. We also use a lot of navigation platforms that three-dimensionally define the child, not just the anatomy, but the tracks, the areas of the brain that were being picked up by the EEG, the areas of the brain that were being picked up by something called a magnetic encephalography, which is a magnetic dipole that indicates an area of a seizure. We can put this all in a three-dimensional volume and guide us in this way. And most importantly, we have the MR scanner right next to us at Texas Children's. This is the interoperative MRI suite. Concept being, we have to be incredibly precise. We have to use good tools, metal tools that aren't going to be able to be put in an MR scanner. MR scanners, you're relegated to plastic. And plastic isn't going to get to the sub-millimetric accuracy that we need. So we do our operation in this big suite here. Here's our robot sitting in the corner. We've just put a laser fiber in this child. This is on the MR table, and here's the coil. And now we are going to transfer this patient into this metalled, modern operating room. We're going to cross this red threshold, and we're going to get into the MR suite, where the environment has to be metal-free to be safe, because metal will accelerate in the magnetic field. So we've made it MR safe by this transition process, and that's been the best of both worlds. The first MR intraoperative MRIs that were created tried to put it right in the OR, and they had to make new titanium tools to do their surgery, and they were horrible. So you could do just the simplest things, and it was a huge compromise in technique and in skill. Now we've got this modern operating room right next to a modern MRI, a 3T, high-resolution Siemens. We have the best of both worlds there. And here we are in the scanner, through the threshold, and then these doors close, and now you are safe. And I'll leave it there.